So here's a roundup of the coronavirus, the picture globally. Cases have breached the 62 million mark. Over 1 million people have died globally from the virus and 32 million people have recovered. In India, it has over 9,300,000 cases, but continues to top the list with the highest number of recovered patients, while the United States continues to be the worst affected country with over 13 million cases and over 272,000 deaths. Brazil is the third most affected country in the world, followed by Russia and France. South Africa, once fifth on the list, now sits at number 16, but leads infections on the continent, which has now breached the 2 million mark. The Africa Centre for Disease Control and Prevention says in a statement that the death toll related to the pandemic stood at over 50,000 with over 1 million recoveries. Southern Africa is the worst affected region, both in terms of the number of confirmed cases as well as the number of deaths, followed by the northern region. Among the countries most affected are Morocco with almost 350,000 cases, under half of those in South Africa, followed by Egypt and Ethiopia with over just 100,000 each. So South Africa has again recorded more than 3,000 new COVID-19 infections this week. In the last 24 hours, 3,198 new cases were identified, bringing the country's cumulative total of coronavirus cases to 785,139. 61 more people have succumbed to COVID-19 related complications. 26 of these are from the Eastern Cape, 15 from the Western Cape, 12 from Kwa-Zulu Natal, 7 from Limpopo, 1 from Gauteng. This brings the national total to 21,439. So amidst all of this, government is said to be considering the reintroduction of level 3 lockdown in parts of the country where the surge in coronavirus cases has been reported. This after Health Minister Dr Zweli Mkhize met with local business and political leaders on Friday in Port Elizabeth. Professor Helen Rees is Executive Director of Wits Reproductive Health and HIV Institute at the University of Witwatersrand. She's also Chairperson of African Regional Immunization Technical Advisory Group and Chairperson of the South African Health Products Regulatory Authority. She talks to us now about vaccine development. Professor Rees, a very good evening to you and thank you so much for speaking to us. Obviously, there's been quite a buzz about vaccines and those that are in the final phases of trials. How important is vaccine development for South Africa at this point, given the rise in cases? And what are the characteristics that we should be looking out for, hoping for?
Yeah, no, it's extremely important. And anyone who was lulled into a sense of security because our numbers had gone down, we are going to definitely need a vaccine to stop the transmission of this virus. And we've seen the numbers go up. In terms of the characteristics of the vaccines we're looking for, we'll look at a lot of things. We'll look at the safety and efficacy of the vaccine, how many doses are required, how it works in different populations, because some vaccines work not as well in people who are older, and yet COVID affects older people in a more severe way than younger people. And we look at things like storage and cold chain. We know that the Pfizer vaccine, for example, requires this ultra cold chain of -70, which would be extremely challenging in the South African and the African setting. And we're also going to have to look at cost, because affordability, for us to be able to buy the amount of vaccine we'll require for the at-risk populations will be significant.
I want to break them down in two themes. I want to start with safety and efficacy. What do we have to worry about? I know when you spoke about trials at some point, you said that there were very few endpoints. Can you just explain this to us?
So in terms of safety and efficacy, the way that we do clinical trials is we start off with a small number of participants can be 50, 60, and even less in some cases, where we just look at the safety and the dosage and the immune response. And then we go on to, that's called phase 1, we go to phase 2, and we again look at safety and the immune response. And if the vaccines look safe and the immune response looks very promising, then we go into these big phase 3 trials that people will have heard about, where there are tens of thousands, 30, 40,000 people in the trial. These trials are mostly designed to compare the candidate vaccine, the vaccine we're testing, against a dummy vaccine, what we call a placebo. So at the moment, they're all designed in this way. And so for the endpoints, what the endpoint of the trial is to look at COVID infection that's been confirmed in the laboratory. And most of the trials have to reach about 120, 130 endpoints or so to show whether that vaccine is actually effective, whether the numbers of endpoints in that vaccine are much lower than in the placebo, because the placebo you would expect not to give protection. So that's what we look for in endpoints. And so the important thing is, one of the problems that's a good problem for China, for example, is that because they've been able to control their infections very effectively, they don't have many endpoints. That makes testing a vaccine more difficult. So at the moment, many of these trials are being done in countries where there are a lot of infections still going on, for example, in the US and the UK, but also in South Africa. But if you have very few endpoints, it makes it, you can't really judge whether the vaccine works or not. So you do need to be in a setting where there is active transmission continuing.
What are acceptable thresholds? And I want to talk a little bit more about some of the vaccines that have shown promising results. You mentioned earlier on the issue of dosage. What has been found to be reasonable or at least effective?
So the dosage will depend, it will vary, and it's very dependent on what sort of vaccine it is, what we call the platform, what type of vaccine this is. But it will also depend from vaccine to vaccine to vaccine. So very early on, what you try and establish is what looks like it's going to be an effective dosage, but you always want to give the lowest possible dosage, but for the best effect. So that we can't say until we've actually got the vaccines there. And some vaccines will require only one shot. Others, most of them at the moment, are requiring 2. And the time between the vaccines will vary as well, between, say, 3 weeks and 4 weeks. So there are many different things, and that will be quite vaccine specific. We've got 2 of the front runners at the moment are what are called messenger RNA vaccines. And they look like, in an interim analysis, to be highly effective at about 95%. There's another vaccine built on a different platform, which is what we call a viral vector, and that's from AstraZeneca. Overall, that looked to be, on an interim analysis, about 70% effective. But when they looked at a smaller number of participants with a lower first dose of vaccine, that effectiveness went up to 90%. The important thing for all of these results is that they need to be looked at critically by a regulatory authority. What we're talking about is what we're reading in the media. A regulatory authority will have all of that detail to look at with a very, very strong scientific and clinical eye, and then decide whether or not they are suitable to be licensed in a particular country.
And you've mentioned some of the vaccines that are really being touted. I want to talk about Africa and what would be program friendly for us, and would it need to be tailored for individual countries? Like South Africa, would they have different needs given the fact that they have more infections and the patterns of the herd infections, etc.?
Well, you're quite right. And as I said, one of the things that makes it very challenging for the African region and for South Africa is these ultra cold chain. And I mentioned the Pfizer vaccine. It appears to be very effective, and Pfizer are now working on a more sort of program-friendly way of developing the vaccine, so it doesn't have to be stored at these very, very cold temperatures. But at the moment, that is the situation. That would be very challenging for the whole of the region, but even challenging for South Africa to be able to suddenly develop that kind of facility to store what will be millions of vaccine doses in this very cold, very profoundly cold chain would be very, very difficult. So those are the sorts of things that we'll all be looking at. But we also need to be sure. For example, we're going to be vaccinating older people. We're thinking if we get a small amount of vaccine in the first place, very likely, and that still has to be confirmed, but very likely we'll give it to frontline healthcare workers who are at the highest risk. But after that, we're going to say what categories of people really need the vaccine because they're most at risk of becoming quite ill. So, for example, people over 65, we know that the rates of infection and the severity of the infection goes up quite steeply in that age group. Now, that's a group that we've never tried to access before. We tried with influenza vaccines, but not as a national program. So we're going to have to think, and how do we access the over 65s? And how do we persuade them, perhaps for the first time in their adult life, that it's a really good idea for them to have a vaccine?
So
and then after that, we're also going to be looking at people with what we call comorbidities who are at high risk, diabetes, hypertension, large numbers of people that we're going to have to find in our health services and develop a system that allows us to find the patients and then immunize them. It's going to be challenging.
And while you're making those decisions, how do you then determine emergency use? Because that's something that you spoke about earlier on. What determines that? And is there an extra cost of that? Because you also mentioned the mRNA types of vaccines.
Yes, so what's happening with those two vaccines, these two, the Pfizer vaccine and the Moderna vaccine, both of these are these mRNA vaccines. They're applying to the FDA in the first instance, and I believe they will be applying also in the UK. But the FDA in the first instance are looking at these vaccines for what the FDA calls emergency use. And that means that they are allowed to distribute the vaccine for an emergency while it's still not fully licensed. And all regulatory authorities, including in South Africa, have the discretion in an emergency situation to give, if you like, provisional licensure or something that you recognize you don't have enough information, you're not going to give a full license yet, you're still going to review it, you're waiting for more clinical trial data, but the product looks so promising and is safe. And then you say, does the benefit of actually making that available as an emergency outweigh the risk? And this is what regulators will be looking at. And so many regulators will look at that emergency use, but it's quite possible that in South Africa, we will get vaccines later. Remember that the United States, the UK, European countries have pre-ordered billions of doses of vaccines. So they are going to have these vaccines sort of hot off the manufacturing press. We are probably going to get these vaccines probably to the end of the second quarter of next year is probably when we're anticipating getting the vaccine.
As you say, Professor Rees, it sounds like a very long, drawn-out process. Do we have the capacity for widespread supply, and do we have the buy-in from communities? Because you were mentioning the various demographics earlier on, and I'm wondering, in tandem, what the messaging has been to all of them to get them to say, yes, I would be willing to be vaccinated.
Well, the capacity, we've got a well-developed, what we call an EPI program. This is what everyone's familiar with. The immunization program for children is very well developed. And, it goes right out to districts and sub-districts, and we're able to get vaccines out to children, even in remote rural areas. So we have that, and we've got that well established. But that's really for small children. So we're going to have to think, and we're going to have to think very rapidly, and this is already happening with the Department of Health. How do we use all of the knowledge to actually adjust this so that we can access healthcare workers, older people, people with comorbidities, as we discussed? So that's the first thing. But you're quite right. One of the most important things that we're discussing at the moment is community buy-in. Importantly, in South Africa and in the region, in fact, but in South Africa, many of our community activist groups who were previously involved with HIV have really sort of embraced this idea that we need these vaccines and that they're in a unique position to be engaged within communities and to get the messages out. But we're also going to have to work with media like yourselves and we're going to have to tailor messages. How do you get to somebody who's 72 years old living in a rural area? Getting to someone like that versus someone who is middle class living in an urban setting who's also 72, different messages and different media access. And then later on, if we want to also persuade young people that they might need a vaccine, or that we want their support for their families, are we going to use social media? So we're going to have very tailored and carefully thought out communication strategies, but it is going to be critically important.
Well, just finally, what are the surveys showing in terms of the people who are saying they're willing? What are the differences? Is it age? Is it people who are in urban, rural areas? Gender? Do any of these play a role?
Yes, it's a very good question. There was a big survey that was done in 19 countries, including in South Africa. And interestingly, older people were more accepting of a vaccine than younger people. But about 2/3 of people said they would accept a vaccine, or probably would accept a vaccine. And about 1/3 said, well, I think I want a bit more information yet. But 2/3 said they would. Women seem to be much more accepting than men, and whether that's because, traditionally women as the caregivers of younger children have been the ones traditionally mostly taking them to clinics, so that they've had more experience of vaccines. And education. People who've been privileged enough to have access to education seem to be more accepting of vaccines than the people who've had less access to formal education. So all of those things will need to be thought about when we're thinking of messaging and communicating. And the other thing we'll have to explain to everybody is, if we only get enough vaccine, for example, to begin with, for say 3% of our whole population, and we have to limit it, for example, to high-risk healthcare workers, we're going to have to explain to everybody why not everyone can immediately get a vaccine, and why we're going to have to wait as we're able to purchase more and access more vaccine to be able to offer this to a broader range of the population.
And Professor Rees, thank you so much. I think also another important question which we'll discuss with you at some point is whether everyone needs a vaccine. Thank you so much for speaking to us. Really appreciate your time. Professor Helen Rees, Chair of the Program and Police Committee of Global Alliance for Vaccines. And she's also, as I mentioned, African Regional Immunization Technical Advisory Group. And that's how we end that section on the update on coronavirus.